Hello again, everybody. We are going to talk here about the always exciting and lovely topic of diarrhea. Yippee. So, most of us should know what diarrhea is. It's the increased volume or frequency of stool, and it's generally of a liquid consistency. So, most patients, when they come into the ED or come to the clinic, they will tell you they have diarrhea, and you can take them at their word because most people know what that is. Most causes of diarrhea are going to be viral. It could also be idiopathic, which generally means viral because we don't have a real way of testing for viral causes of diarrhea. And most cases are really self-limited. Now, when a patient comes into the ED and they say they have diarrhea, the most important first step is to assess the fluid status of the patient. A lot of patients, particularly older patients that don't have access to fluids, patients who might not be well taken care of, they may be at a low fluid state. And so all patients with hypotension or patients who have fallen or who are dizzy should be given immediate IV fluids. And when I say fluids, I mean a normal saline bolus. All patients who have hypotension or orthostasis requiring fluids, or patients that have severe pain with their diarrhea, or diarrhea that's accompanied by fever or abdominal tenderness, all of these patients should be admitted to the general ward. Now, diarrhea can be classified in two ways. You can have acute diarrhea, so diarrhea that's lasted for longer than 2 weeks, or you could have chronic diarrhea, which is diarrhea that's lasted longer than 2 weeks. 2 weeks is generally the point where we divide acute and chronic because most cases of acute diarrhea are self-limited within those 2 weeks. So if it lasts longer than 2 weeks, we will generally shift our differential to a different set of diagnoses. In acute diarrhea, so a diarrhea that's lasted longer than 2 weeks, first, you should always rule out infectious causes. So how do we figure out what's causing the diarrhea? First off, let's talk about the different causes of acute diarrhea. We have infectious, which we divide up into bloody and non-bloody, and then antibiotic-associated diarrhea, which is the C. diff diarrhea that you've probably seen on the wards, and then lactose intolerance. Okay, so how do we figure out what is causing the diarrhea? The best thing to do to find out what's causing the diarrhea is a stool study. And a stool study is not really one test, it's a set of tests, and you basically have the patient's stool and you do these different tests on it. So yes, it's good to get your CBC and your CMP and have all your routine labs, but the most important test are your stool studies. And I would say out of these stool studies, out of these 7 things that I have listed on here, the number one most important one for acute diarrhea is your stool lactoferrin. And this is important because if you have white blood cells in your diarrhea, in the stool, then you know that this is bloody diarrhea, and that's going to change what pathogens you are thinking that this might be. Stool red blood cells are good to have, but generally if you have white blood cells in your stool, you'll also have red blood cells in your stool. Ova and parasites are good they're not good to see, but it's a good test to have, ova and parasites, or Giardia antigen. Either one can be used. Generally, we use the ova and parasites test to look for Giardia, but Giardia antigen is another test that you can use to look for Giardia. If you have a choice, Giardia antigen is definitely the better one. It's more specific, but ova and parasites can be used too. And ova and parasites are also used for other parasitic causes of diarrhea. A culture is useful to have And a culture is not going to be useful for you right away because it takes a couple days for the culture to come back. But if you have a diarrhea that is not responding to antibiotics, then it will be good to have that culture because then you'll know what it is, so that 2 days later, if the patient hasn't responded to therapy and they're still having diarrhea, then you can target that specific pathogen. The C. diff toxin is good to have when you are suspecting antibiotic-associated diarrhea. So unless the patient is on antibiotics, then it's really not necessary to get the C. diff toxin. The stool osmolar gap is going to be useful for diagnosing diarrhea that's caused by lactose intolerance, or for diagnosing diarrhea that's caused by laxative. So in this case, you could even think like Munchausen syndrome, where a patient could be taking laxatives, then coming into the ED saying they have diarrhea. A stool osmolar gap will help you be able to tell if it's laxatives or if it's any kind of osmotic force that's causing the diarrhea rather than a pathogen. And then a fecal fat study will tell you if you have fat in the diarrhea, which will be useful because that will tell you if this diarrhea is being caused from a malabsorption. Generally, the fecal fat malabsorption, that's going to be more with the chronic diarrheas. Okay, so you get your stool studies back on the patient, and it comes back with a positive stool lactoferrin. So what that means is that the patient does indeed have blood in their diarrhea. And so what you should gather from that is that you don't necessarily need to see frank red blood. You don't even need to see melena to diagnose the patient with bloody diarrhea. All you need to do is see the positive stool lactoferrin. And so going back to this, yes, we do order red blood cells. However, you don't have to have red blood cells present to have bloody diarrhea. So this really just hinges on the lactoferrin. And if the patient does have bloody diarrhea, lactoferrin positive stool, then there are many things that it could be. But the USMLE will expect you to know that two of the most common causes of bloody diarrhea are Salmonella and Campylobacter, and these are both associated with foodborne illnesses. Some of the other causes include Shigella, Yersinia, EHEC, E. coli 0157H7, Entamoeba histolytica, and two of the Vibrios, which are Vibrio parahemolyticus and Vibrio vulnificus. So some associations with these, as I mentioned, both Salmonella and Campylobacter are associated with foodborne illnesses, typically with poultry, eggs, and milk. Campylobacter is associated with the Guillain-Barré syndrome, and this is something that will develop after the gastroenteritis, after the diarrhea. And so that may be in a vignette that the patient is developing ascending weakness, and they recently, 2-3 weeks ago, had a diarrhea illness, a GI illness. Campylobacter has been associated with Guillain-Barré syndrome. Another thing it can be associated with is reactive arthritis. With E. coli 0157H7, this is associated with the development of hemolytic uremic syndrome. So you have to keep an eye on this, because in the event that the patient has this type of diarrhea, they will drop their platelets. And if they do drop their platelets, it's important to remember never, ever, ever to give them antibiotics or platelets. So let me rephrase that. You have a patient with bloody diarrhea. For most of these, pretty much all of these, you're not going to give antibiotics in the first place. With diarrhea, even if it's bloody, you don't need to give antibiotics. The GI system will naturally expel the bacteria, and it will self-resolve. What you're mostly concerned with is the patient's fluid state. But particularly with E. coli 0157H7, the last thing we want to do is give them antibiotics, because that's going to worsen the hemolytic uremic syndrome. In addition, what we don't want to do is give them platelets. And you would think, well, hemolytic uremic syndrome, the platelets are low, we should give platelets. And really, we shouldn't, because you're just going to worsen the hemolytic uremic syndrome if you give platelets, because it's really a disorder that affects the platelets, and you're just going to perpetuate the cycle. So if you have a patient who has had diarrhea and who has a low platelet count, you really should be thinking of O157H7, and in that case, you're not going to give antibiotics, which you usually won't anyway, but particularly you're not going to give them platelets either. Vibrio parahemolyticus is commonly associated with shellfish consumption, and Vibrio vulnificus has an increased incidence in patients who have liver disease or a high iron state. So, for treating patients with bloody diarrhea, if the patient is stable, if their fluid state is fine, it's fine to just observe them. Fluid replacement is going to be really important, and generally you want to make sure that you're using a isotonic fluid, so like Gatorade or Pedialyte. But if you have to, if all you have is water, that's fine. Fluid replacement is the most important. If the symptoms are severe, so really if the patient is in a bad enough state to be hospitalized, then you can use antibiotics. But definitely, if you want to use antibiotics, don't wait for the culture. So we're going to treat them empirically if we use antibiotics. And what we'll use is ciprofloxacin. We can use really any fluoroquinolone, but ciprofloxacin is the most commonly used. And we can add metronidazole to that, but we don't have to. So ciprofloxacin and metronidazole. If the history points to Vibrio vulnificus, and this is really the only reason that I brought up that vignette, if you have a patient with bloody diarrhea and they also have liver failure or they also have hemochromatosis, then you should use doxycycline either in substitute or in addition to ciprofloxacin, because there is a possibility that this patient has Vibrio vulnificus. And Vibrio vulnificus, really the only reason it predominates in patients with high iron states or with liver failure is because Vibrio vulnificus itself eats iron. It's a bacteria that thrives off of iron. So add doxycycline to any patient with liver disease or high iron if they have bloody diarrhea. And like I said, most cases are going to be self-limited. Some of the non-bloody diarrheas, so this is if you have a negative stool lactoferrin, includes Giardia. And Giardia, remember, is the diarrhea that's associated with patients who are out camping, they drink stream water, and they develop a very bloaty diarrhea. And usually it is ova and parasite positive. It's usually very malodorous because there's oftentimes malabsorption with Giardia. But in addition to its association with camping and stream water, you can also get it through oral anal sexual contact. So this is, as you can imagine, something that is excreted in the feces, and you can get it by consuming that feces, so to speak. If the feces is in the stream water, or if you get it through oral anal sexual contact. And important to remember with Giardia, the big one here is the ova and parasites will be positive. You can also get a Giardia antigen, which is more specific to Giardia itself, and that will diagnose this. Also remember the severe bloating, and that has to do with the malabsorption. Bacillus cereus is associated with Chinese food, especially fried rice that's been put in the refrigerator and then reheated. This has a tendency to cause vomiting, but certainly vomiting is not specific to any of these in particular. But remember, the USMLE loves to throw the reheated fried rice, the association with Chinese food. Staph aureus is associated with dairy and coleslaw and ice cream and picnics and summer eating because of the dairy association. So here we're thinking of like sour cream or coleslaw or mayonnaise that's been sitting out at a picnic lunch for too long, and the patient eats it and they get the Staph aureus. Clostridium perfringens is associated with meat that's been sitting out too long. And then these other ones are a little less common, but these are associated with HIV, particularly patients who are into full-blown AIDS, and this is Cryptosporidium and Isospora belli. And what you can get here is an acid-fast test, and the acid-fast test will be positive. Also the ova and parasites. And then the last but not least, the viral causes of diarrhea. These are the most common causes of acquired diarrhea, and you'll particularly see this in children. Rotavirus is #1 cause. So how do we treat non-bloody diarrhea? Well, in general, we treat it the same as bloody diarrhea. If the patient's stable, observation and fluid replacement is adequate. If the symptoms are severe, then you can go ahead and treat them with antibiotics, and you're going to just use the same antibiotics you use for bloody diarrhea. This is just this is an empiric therapy. It covers gram-positive and gram-negatives, and it really covers all the pathogens that could cause diarrhea in immunocompetent people. As far as AIDS patients, if they're diagnosed with Cryptosporidium diarrhea or with Isospora belli, #1 thing you want to do is make sure they're compliant with their antiretroviral regimen. So HART is just your big term for highly active antiretroviral therapy. Just make sure they're compliant, and you want to get their CD4 counts up to above 100. That's the best treatment for cryptosporidosis. With Cryptosporidium, though, you can also use paromomycin or metronidazole if you want, if it's severe enough. But paromomycin is one of those drugs that you don't see very often, but with Cryptosporidium, it is probably the single best drug if you had to choose a drug to treat Cryptosporidium. But the best thing to do for these patients is to make sure they're compliant on their antiretrovirals to get their CD4 counts up. For Isospora belli, if you have an HIV patient that has non-bloody diarrhea and they come back positive with an ova and parasite, then you can treat them with trimethoprim sulfamethoxazole. And with non-bloody diarrhea, as with bloody diarrhea, most cases are self-limited. So for outpatient management, for the patients that don't require hospitalization, you're going to treat them in kind of the same way, except you're not going to use antibiotics. Just remind the patient of the importance of adequate hydration. Gatorade and Pedialyte are like probably the best things you can use, and don't be afraid as an adult to go get Pedialyte or to recommend to your adult patients to go drink Pedialyte. It's a really, really, really good source of electrolytes. Gatorade is fine too, but Pedialyte is really good. I have no problem recommending Pedialyte to my adult patients. Any hydration, though, is better than nothing. So water is okay if they have to, but Gatorade and Pedialyte are the best. Basic food safety education is always good to know. I kind of gave you a little bit of that earlier, but make sure these patients aren't leaving their food out. Make sure they're refrigerating things, putting things in a shallow dish, especially now with the summer coming on, with picnics and everything. Food safety is pretty important to keep in mind. And then make sure you tell the patients to return to the clinic if the diarrhea has persisted for longer than 2 weeks. So if they've had the diarrhea for a week, tell them to come back next week if it hasn't gone on, because then it's chronic diarrhea, and we have to work up for other things. Okay, so shifting from the infectious causes of diarrhea, this is also an infectious cause of diarrhea, but in a different way. So antibiotic-associated diarrhea is caused by Clostridium difficile, and Clostridium difficile is a diarrhea that forms, it's a pathogen that forms a plaque on the large intestine. And so this is very common in hospitals because we give antibiotics in hospitals, and because as physicians, nurses, etc., we carry Clostridium because we see so many different patients. So it's just an overgrowth of Clostridium difficile in the large bowel, and any antibiotic can precipitate it, but particularly clindamycin is associated with antibiotic-associated diarrhea. Now, don't confuse it. We don't use clindamycin to treat antibiotic-associated diarrhea. It's associated with the development of antibiotic-associated diarrhea. Definitely suspect antibiotic-associated diarrhea in any patient who is on antibiotics and they're presenting with diarrhea. So one of the things you should always ask a patient when you're on the wards or when you're in the ED or when you're in the clinic and a patient has diarrhea, ask them if they're on antibiotics, because if they are on any antibiotic, you are going to check their stool for C. diff toxin. The diagnosis, of course, is going to be a positive C. diff toxin. Treatment will be metronidazole or Flagyl. That's the best treatment to use in patients with C. diff diarrhea. And if their symptoms abate, if they go away or get better, and then the diarrhea reoccurs, you're going to retreat them with metronidazole. You can also use vancomycin, but metronidazole is the best drug. So give them metronidazole if the symptoms abate and then they reoccur. Then you're going to give them metronidazole again. You're not going to give them a different drug because clearly the pathogen was responsive to metronidazole, but either you didn't give them a big enough dose or they weren't on it long enough. Now, if the symptoms don't ever show any improvement after 2 days, then instead of metronidazole, you're going to switch them off and you're going to put them on vancomycin. And you're not going to give them IV vancomycin. Why? Because vancomycin does not cross into the bowel wall very good. So you're going to give them PO vancomycin because if you take it orally, it will be in your bowel. So you'll give them PO vancomycin if they fail metronidazole. All right, now lactose intolerance is very, very, very common, and this is kind of going to be on the border of acute and chronic diarrhea. So lactose intolerance can cause a chronic diarrhea if the patient hasn't came in and they've had the symptoms long enough, but usually it will present rather acutely. But it can be either acute or chronic diarrhea. I included it here, though. So this has a high frequency in the general population. Most people have some degree of lactose intolerance, some more than others. So lactase is actually the enzyme that you lack that causes the lactose intolerance. So lactase breaks down lactose, and remember lactose is a 2-sugar molecule, and it's glucose and galactose. And if you don't have the lactase to break down the lactose, then the bacteria in your large bowel will break it down for you, and unfortunately, when the bacteria break it down, it creates CO2 gas, and the sugars, the glucose and galactose, will sit and remain in the large intestine. And so there's 2 problems with that. 1, you get gas. 2, you've got sugars in the large intestine. And what do sugars do? They act as an osmotic, and they pull water out, and that's going to cause diarrhea. The diagnostic giveaway for patients with lactose intolerance is that they have an elevated stool osmolar gap. So the stool osmolar gap becomes useful when you have patients that don't have any risk factors for infectious diarrhea. They don't have a positive white blood cell. Then it's good to get that osmolar gap because then you can see if there is an elevated osmolar gap, and they always will have an elevated osmolar gap in lactose intolerance. And so elevated stool osmolar gap in an otherwise healthy patient with diarrhea. The diagnosis and the treatment is going to be to avoid dairy. The symptoms will abate in 1 to 2 days, so that should actually be your diagnosis. You can tell these patients to just avoid dairy, and if the symptoms go away in 1 to 2 days, you can actually then just simply diagnose them with with lactose intolerance. So you don't necessarily have to do the osmolar gap, but that's the best way to diagnose them. But another thing you can do is to just tell them to avoid dairy, and if their symptoms abate in 1 to 2 days, then you can pretty much diagnose them with lactose intolerance. Lactase supplements are okay for patients. They're good for patients with lactose intolerance. That will allow them to intake a level of dairy. Yogurt is an exception. Yogurt doesn't contain high amounts of lactase. So as far as chronic diarrheas, lactose intolerance is one, as I mentioned. Carcinoid syndrome is another one that I'm going to talk about. Inflammatory bowel disease I sort of addressed in a different lecture. That includes Crohn's and ulcerative colitis. Irritable bowel syndrome I addressed in another lecture. That's primarily a syndrome of pain that is relieved by bowel movements. And then malabsorption is a diarrhea that's caused by the lack of absorption of fat in the small intestine. And that includes various etiologies such as celiac disease, chronic pancreatitis, and a couple infectious causes, which are pretty rare. So just to kind of sum these up as I did, lactose intolerance is a chronic diarrhea or an acute diarrhea associated with dairy. Carcinoid syndrome is a chronic diarrhea that's accompanied by flushing, tachycardia, and hypotension. Inflammatory bowel disease is a chronic bloody diarrhea that's associated with fever, abdominal pain, and extraintestinal manifestations. Now remember, we have acute bloody diarrhea. Those were the infectious causes. Inflammatory bowel disease is a chronic bloody diarrhea. No pathogen should give you bloody diarrhea that lasts for a month. Irritable bowel syndrome is a chronic diarrhea that's primarily associated, it's always associated with pain, and it remits with a bowel movement, and generally you don't have the symptoms at night. And then malabsorption is a chronic diarrhea that's positive for fecal fat. So carcinoid syndrome, I'm just going to address here quickly. It's a chronic diarrhea that's caused by a serotonin-secreting tumor. It's pretty rare. The serotonin-secreting tumor can be pretty much anywhere, but most commonly it's present in the appendix, small bowel, and bronchi. The symptoms are going to be chronic diarrhea, but a lot of times, well, the diagnostic giveaway, and you should always ask patients this, even though it's rare, is do you ever have flushing, feel like your face or your extremities get warm? Do you have you had any dizziness episodes? Do you have any palpitations? Those are all things that would indicate tachycardia and hypotension. So flushing, tachycardia, and hypotension, those are all signs of elevated serotonin. Remember, these are some of the same symptoms that you get in serotonin syndrome. So chronic diarrhea associated with episodes of flushing, tachycardia, and hypotension. If you suspect carcinoid syndrome as the cause of diarrhea, the best diagnostic test is a urinary 5-HIAA. That's the same way we diagnose serotonin syndrome. And HIAA is just the abbreviation for hydroxyindole acetic acid. So that's how we diagnose it. The treatment, rarely are these tumors, we usually can't resect them. So generally the treatment is octreotide.